Hello and welcome to this HCPLive peer-to-peer discussion. My name is Juan Pablo Arab. I'm a transplant hepatologist at Western University in Ontario, Canada, and I'm joined by Dr. Banerjee. Today's discussion is centered around the potential of resmetirom, but also how a potential movement in the therapeutic pipeline has changed discussion around the management and screening of patients with MASLD. Dr. Banerjee, if you could introduce yourself to our audience, then we will begin our discussion.
Thank you very much, Dr. Arab. My name is Rajarshi Banerjee, or Banjo. I'm an internist in Oxford, England. I'm also CEO of Perspectum Diagnostics, and I've published quite a lot of research on how to identify liver disease using MRI and other diagnostic tests that are not biopsy.
Thank you very much, Banji. So before we dive into the potential impact of the approval of in this space, let's take a step back and acknowledge the big news coming out of during 2023 with the change of the nomenclature for steatotic liver disease. So to begin our conversation, what factors prompted the transition from using the term non-alcoholic steatohepatitis, NASH, to metabolic dysfunction associated with steatohepatitis or MASH in the recent years, and how does this name reshape our understanding on the liver disease?
Very good question. I don't think anyone was a fan of the term non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. It's not unique in medicine, but it's not good medicine to define something by first saying what it is not. You know, I shouldn't be defined as non-Dr. Arab. Does it make sense? Should be defined by what I am, not by what I am not. And so non-alcoholic was yes, you have to establish an alcohol history in a patient who has suspected fatty liver disease, but I don't think you need to put it in the disease definition. If we think someone with steatotic liver disease has a metabolic origin for their condition, which is the majority of patients, I think the nomenclature starting with metabolism makes sense. Some may argue that metabolic dysfunction associated is a little bit clunky, and I would be one of them, but it's better than non-alcoholic. And then this is the 21st century, so whilst historically we may have called it fatty liver disease, going forward it's much better to not have pejorative labels, and so steatotic liver disease as the umbrella term for the group of illnesses characterized by excess ectopic fat accumulation in the liver, I think is appropriate. So overall, I think moving from NASH to MASH is a good thing. The pieces around M, I think perhaps are a little bit clunky, but it's a good start.
Agree.
From my end, because the symptoms are often non-specific, it can be challenging to recognize and diagnose MASH. In your opinion, Dr. Arab, when should patients be screened for MASH?
So yeah, that's a great question. And if we consider that MASLD, like the prevalence of MASLD globally is around 30%, so between 25 and 35, it's difficult to, screen 35% of the population. So we need to define which are the high risk groups. So I will say we need to screen high risk patients. And, the long hanging fruits there are those populations that we know that are going to have high prevalence of MASH. So with the steatohepatitis, with inflammation. So those that are at risk of progressing to more advanced liver disease, including fibrosis and cirrhosis. And those will be probably patients with diabetes. So we know that 70% of the patients with diabetes are going to have MASLD, and probably around 15% are going to have MASH. Also patients with obesity. We know that patients with obesity, also 70% are going to have MASLD, and 90% in those patients with morbid obesity. So I think those are some ways how we can stratify. Other populations are patient more than 50 years old with other metabolic dysfunction or metabolic syndrome, such as hypertension, dyslipidemia, or metabolic syndrome itself. So I think that's the way how we can try to identify those patients with MASH, which are more likely to progress, and also make sense from a public health perspective on trying to recognize the patients that are at higher risk of having bad outcomes. And MASH is not only associated with the progression of liver disease, but it's a marker of metabolic dysfunction. So this patient, we need to remember that the first cause of death is actually cardiovascular, having MI, strokes, and also cancer. So I think that is the way how I will try to identify the patient with MASH, in line with trying to identify those that already have progress of the fibrosis process, such as using, FIG4 or any other simple ways to stratify the patient that may have already progressed.
No, I completely agree. I mean, we published a paper last year, Roca Fernandez et al. In the Journal of Hepatology, where liver CT1 predicted cardiovascular outcomes, and that was in UK Biobank, 33,000 people. And it predicted cardiovascular outcomes more than most common cardiac risk factors. And so the cardiology community got excited because with the advent of drugs, you now have a new modifiable cardiovascular risk factor. The biggest trick with statins is that statins work in the liver, but nobody admitted it because people care about their hearts.
Yeah.
So I think it's a really exciting time for all of medicine, not just hepatology. Prometheus is winning. The liver really matters. What we found is, if you look in Dallas, we scanned 900 patients as part of the Dallas Hearts and Minds study, and 93, so almost 10%, or over 10% in fact, had MASH defined by imaging, so liver fat greater than 5%, and CT1 greater than 875 milliseconds. That's a lot more than here in the UK. In the UK, the prevalence of MASH on imaging is about 3.5%, and the same the NHANES study in Harvard. The difference, of course, with those two latter populations is they're younger and they're more Caucasian and they're more professional. Yeah. So I think the true prevalence of MASH and steatotic liver disease will depend on the population you are looking at, and some form of blood test ahead of perhaps a more advanced test like liver multiscan kind of makes sense. And we're now at the stage where we can define what those pathways are and make the MRI more accessible to patients. So I'm very excited for our ability as a group of physicians, backed by the payers and with lots of providers, to be able to offer a diagnostic pathway to patients that doesn't include biopsies. I'm not anti-biopsy, but I don't think we can see 2 million Americans with biopsy.
No, that's true. And as you highlighted, there is other factors that are affecting not only the prevalence, but the speed of progression of liver disease. For example, we did a study in South America, and we assessed the polymorphism of risk, the PNPF3, where, in Europe is around 6% or so, 5-6%. In like our Native American population in South America was 80%. So it's very frequent, and that also may tailor the interventions, the way that we screen, the way that we intervene. So I agree with you. We need to somehow identify the high-risk populations and then make the screening in a way that it makes sense for the health system and for the population itself. And linked to that, so after we make the diagnosis, so while there is no currently FDA-approved treatment for MASH, Resmetirom, an oral treatment for MASH, is being evaluated in a phase 3 clinical trial that was just published this month in the New England. So what do we know about the key clinical outcomes there?
So, I mean, for me, I think 25% of patients had an improvement compared to 10% in the placebo arm. And on the high dose, it was closer to 30%. So that's a significant, improvement on placebo. And it's the first time a drug, I think, will get approved or might get approved. We don't know yet. Because of its ability to treat steatotic liver disease with inflammation or fibrosis or both. And there was material fibrosis improvement, specifically improvement in the Kleiner-Brunt fibrosis score in about a quarter of patients. So I think this is a first for the liver world. I don't know whether this drug will improve cardiovascular outcomes. We'll find that from real-world data very quickly. But I mean, for me, this is a drug that I would definitely consider prescribing in my practice when it became available in the UK. I know, obviously, from the Canadian perspective, it's not there yet, but in the population of patients with MASH that you see, would you prescribe resmetirom to many of them?
I mean, no. I mean, I will prescribe it. We don't have it yet. Right?
No, assuming it comes on the market.
Yeah, I mean, for the MASLD or MASH population, for sure, especially being the first drug to be approved, is oral, so once a day, is liver directed, and the side effect profile beside diarrhea and nausea that was same, I think, even in the placebo group, with these outcomes or with these results, I think it's very encouraging to prescribe it.
Good, excellent. And how would you monitor your patients when they started on the medicine?
So that's a great question for the people in the audience that maybe is not familiar with the drug. This is a thyroid hormone receptor beta selective agonist. So basically, these TGR5 receptors in the liver is also in the muscles. I think we need to, from one side, monitoring if the drug is being effective, and on the second hand, we need to monitor if we have any side effects. The main side effects on the trial were diarrhea and nausea, so that will be asking the patient. The drugs bind also muscles, so probably having creatine kinase down the road is a good idea. And then we need to monitor in terms of, from a liver perspective, aminotransferases. I will probably follow with transient elastography in a non-invasive way to assess fibrosis. And also, if you have the CAP or another way to assess steatosis. I think that will be kind of, from a liver perspective, the way to assess both inflammation and also fibrosis. I don't see in clinical practice, honestly, doing liver biopsies for these patients unless they are not improving. If they are not improving, well, you need to think that maybe there is a second or diagnosis, or there is something that you are missing, and you may want to have a liver biopsy. But I think just for follow-up, we won't do it. And then when we start getting real-world data, the question will be what you already highlighted. So beside the liver, because it's liver-directed, what happened with cardiovascular outcomes, or what happened with, the other disease burden that is associated with MASLD. So that's probably how I will follow these patients.
No, I think it's very similar for us. The only difference, I think with patients on the drug, we know that it seems to have some material efficacy at about 6 months. And so when it's available, we'll probably get people at about 6 months with standard test liver enzymes, maybe FIB4, something like that. But we don't really expect a big change in FIB4 in 6 months. And then a repeat MRI to make sure that they're going in the right direction. FibroScan for monitoring for us, transient elastography for monitoring for us isn't so useful just because the variance is so great. So we won't really be able to see if they're getting better or worse. But that's, depending on availability of technology. I know in the United States, a lot of payers don't cover FibroScan for monitoring, although they will support it for diagnosis. So I think we have a role there in monitoring therapeutic efficacy. And I totally agree with you. If after 6 or 12 months someone's not improving on resmetirom, either consider an alternative pathology for example, autoimmune hepatitis,
Mm-hmm.
or switch to a different agent if one is available. But, that's 75% of people who may not respond, but that was on biopsy criteria. Maybe on more sensitive imaging or blood testing criteria, more people will respond.
I agree, and probably this is going to need to be in a long run. I know that we want like immediate results for everything, and that may be true for the inflammation, but the fibrosis portion, it takes time. I mean, all studies of bariatric surgery show that fibrosis continue improving even after 5 years. So this probably will need to be in the long run.
Yeah, excellent. Okay. From my side, I guess the last real considerations are, in this study, talking about fibrosis, there were specific proportions of people with different levels of fibrosis. Now, remember, I'm not a hepatologist, so I'm probably less fussed about fibrosis than many. I am more fussed with inflammation and cardiovascular risk, but it takes many doctors to make up the world. But at least 50% of the MAESTRO study patients, I think, had fibrosis F3 or more, which is coloring the judgment of many other people coming into this space as in should they be targeting F3 or more. But no more than 15%, I think, of the population had F1. So the study is really skewed towards patients with more fibrosis.
Yeah.
What are your thoughts on that?
So I think there is 2 points there. Number one is that the proportion of advanced fibrosis versus early will depend on the setting. So if we are in a primary care office, probably most of the patients are going to be at 1F0 with MASLD, right? If we're in the liver transplant center, probably most of the patients that are referred are going to be F4. So I think it will depend on the practice. For example, we have a MASLD clinic where it's supposed to all the patients without cirrhosis go there, but that has more than only isolated MASLD without inflammation. So probably reflect the intermediate population, but still I will say like 80% are F1 or initial F2 versus 20% are F3. So still, I will say that majority of the population are at the early phases of the disease. And it depends, again, on the risk factors, on the year since the diagnosis, and the setting. That will said, I will say that, again, we need to focus, probably if we need to start as a starting point, I will focus on the population that has the higher risk of bad outcomes. So if we need to treat probably the F4, although they may benefit still, probably that's a population that it will be harder to treat and to see results. But I will focus on the population F2, F3, because it's where you can get the highest benefit. Because if you stop the progression and even improve those patients, you can avoid all the associated burden of disease, and you can avoid them to become cirrhotics, and then with all the complications associated to that. I won't focus on the patient without any fibrosis, like the F0 without MASH, that 30% of the population. And still, you may find in the future that, if you use this as a prophylaxis, maybe they benefit. But again, we need a starting point, I will start with the F2, F3, because it's likely the population that is going to benefit the most.
So here in the UK, I mean, and in many other countries, I think in many parts of the United States as well, there'll be some sort of blood test and then some sort of scan. Here we use, for example, AST thresholds, and then a corrected T1 from liver multiscan greater than 875 milliseconds to determine who goes on treatment. What will your thresholds be when the drugs become available to start treating? Will it be a FibroScan or a CAP threshold or something like that?
Yeah, most likely it's going to be based on fibrosis, and the most available is transient elastography. So I will say that everyone that goes in the range of F2, F3, they may benefit from the drug. Probably that is going to be approved by the FDA to start with. But again, you can make the case that even patients with more advanced disease will benefit, because
Yeah.
there is not only a stop of the progression, there is some regression. And even early the disease process, you can say, well, maybe we have a patient that has, MASH without fibrosis. If we resolve the MASH, we'll never develop fibrosis.
No.
Uh,
And what are your thresholds? So, because we struggle with transient elastography to distinguish between F0, F1, F2, F3. We're pretty good at F4, but
yes.
what thresholds do you use in Ontario to distinguish F1 from F2?
So it depends, but I will say like the simple rule is like less than 8 is probably, non-significant, so F1 or less. More than 12, probably like the ruling. So most likely has, S4, although you can say till 15. So probably will be something there between, 8 and 15 or 8.
So people with a transient elastography 8 to 12, you would put on resmetirom.
Yeah.
Yeah. Okay. That's perfect. Okay. That's really interesting. And then I guess with the last thing, how does this alter your our earlier conversation about how to screen asymptomatic patients? Here in the UK, our hospitals are completely full, so we have no space to screen more patients. So the government is investing in outpatient community diagnostic centres. I run one actually here in Oxford, where patients come in, they park, they come in, they have a blood test, they have a scan, they can have a FibroScan, they can have an MRI, whatever. And then the doctor determines whether or not they should go on a drug. The primary care doctor prescribes it, and it can be an electronic prescription. So that's the pathway that all the MASH drugs will be prescribed on. Now, initially, there'll be some specialist clinics where that's piloted, but it'll be in community diagnostic center settings in the same way that we do respiratory clinics downstairs. That's how we're going to answer the scaling problem of providing effectively a new service that's really preventative care. How's it going to work in Canada?
Yeah, that's the key. I think the key medicine now is preventive medicine. We can't keep being reactive, like waiting for the patient with cirrhosis coming to the liver transplant centers. We need to do prevention. And the problem there is how we allocate resources. Like we say, okay, well, let's screen MASLD, 30% of the population. How we do that? I mean, there is no care system that can do that. So how we stratify patients. How we are doing now in Ontario is basically we are triaging patients according to the risk of advanced liver disease, and we do multi-steps. So at the primary care level, patients are getting FIB4. So based on FIB4, we see if the patient is a low risk, is a moderate in the intermediate range, or high risk. Patients that are high risk are going to get some time of elastography. So we have FibroScan in place, but we also, in our hospital, every ultrasound machine now is equipped with shear wave. So they are getting shear wave elastography. And that's before being seen by the liver doctor. Because if we are waiting that all these patients are going to be seen, that's unrealistic. So that's a triage that happened backstage, and that is before the patient to our office. So we are putting in this specialized MASLD clinic all the patients with F2, F3. If they have F4, they are to the hepatologist's office. If they have F1, they go back to the referring GP or primary care provider with some specific recommendations and when to test again. So you may need to be retested in 1 year, in 3 years, in 5 years. So I think that will be the way to handle all these patients. I strongly believe that we need good assessment, non-invasive assessment of these patients. Fibrosis is one thing, and I think the liver field has focused pretty much on fibrosis. But again, I think we need to go even one step before and see, well, which are the patients with inflammation? Where is the steatohepatitis? Because we know that that's a driver of the disease, and not only the liver disease, the cardiovascular disease, the cancer, and everything. So I will say, but as we do with other disease, we don't need to reinvent the wheel. So I will say, well, we have patients with, ultrasound for any reason, and there is steatosis or there is elevated liver function test, and we triage. So is this patient low risk, moderate risk, high risk? And then we need to take action with that. And I will say that one thing, look, what we have right now is doing a FIT4, and if it's high, going for an elastography. But probably in the future, we'll be having an additional test to see, you have steatosis, or you have some elevation in your liver function test, or you are diabetic, or you have obesity. Well, let's test for steatohepatitis without a liver biopsy.
I completely agree. And I think the scalability of it is very important. I know Professor Kim, he's president of AASLD right now, and a professor of hepatology at Stanford. He's not a big FIB4 fan, because he says that it misses too much disease, but you have to have something in primary care to pick up some people. So at least it'll capture some of it. So I think there's a role. And there's other, Siemens are pushing ELF, which is also very good, but is a bit more expensive. So it's not widely available. And then obviously tests like ours, MRI are coming through. And then EchoSense is obviously making FibroScan more broadly available. So to doctors worried about their patients with suspected liver disease, I'm hoping that over the next couple of years will increase the accessibility of tests. Certainly, if you look at the big manufacturers like Siemens, they've mapped out where they're going to put scanners on trucks to supply gastroenterology clinics and all this sort of stuff. So it's going to be a very exciting time in terms of scaling.
No, I agree. And then probably the message there is every health system will need to define how they are going to do it. And that will be influenced by resources, by accessibility, but also by the population. So there's going to be populations that are at higher risk than other populations, and they will need to define it. But at the end, will depend on the population, on the resources, on the accessibility, and I think every health system will need to develop a system. For right side, I think the easiest way is just going for the long-hanging fruit, so diabetics or patients with obesity. Actually, we did a couple of years ago a very nice study where we went to the diabetic clinic. So we asked doctors there to let us know every first diagnosis. So a patient that were just diagnosed with diabetes. The patient, when they were coming out from the clinic, we offer an MRI. So we say, okay, you were just diagnosed by diabetes. Did you need it before? No. Hey, do you want an MRI for free? And we found 14% of advanced fibrosis and 6% of cirrhosis in unselected diabetic patients. So I think that's kind of a population that is a high risk and where you can really screen and have an impact.
No, I completely agree. Excellent. Well, Dr. Arab, it's been an absolute pleasure talking with you. I think this concludes our conversation today. Thanks to our audience. Thanks once more to Dr. Arab. And thank you for tuning in to HCPLive for this peer-to-peer discussion.